Hello, welcome to everybody. I'm hoping and presuming everybody can hear us clearly on this. If not, please wave a hand or mention it in the chat for our colleague Emily to look at while I'm trying to give the presentation today. This is a very dense presentation. It has a lot of slides and a lot of information, so please feel free to write down any notes you can as well as you can. The time for questions is probably less than we usually have and then less than I would like. Hi, Jason, good to see you. We are going to start with introductions, the usual slides. We'll get into the physiology a bit and some of the things to watch for in opioid use disorder in the elderly. We'll have 4 cases and then a reminder at the end as to how to look for opioid use disorder. And again, more questions if we can. This is the Massachusetts Consultation Service for the treatment of addiction and pain. The MCSTAP service, it is an on-call and we answer as immediately as we can, often immediately. Between 9 a.m. and 5 p.m. Monday through Friday. We have several consultants, over a dozen from across the state. I represent the most western rural part of our group. And if we go to the next slide. Okay, this is our mission. Many folks have seen this slide before. The slides should be available afterwards, I hope and believe. So I may go quicker than you may be able to read some of this. Next slide. Okay. This is our list of consultants with a nod and wish you were here, Jim, as well. We will have Chris Shannon as well, joining us about halfway through. I have no financial disclosures. These views are mostly my own, but with significant input from Chris and members of the team. And I'm happy to go forward. Next slide. Okay. These are our learning objectives. Understand that there's a rising use in the elderly and use disorder in the elderly, that the normal physiologic changes of aging do apply here. There are common risks that are perhaps even worse in older individuals, and we'll review opioid use disorder and look for safer practices. Thank you. Next slide. The goal for most care, all care, MCSTAP consulting care, especially around these issues of chronic pain and opioids, is to have no stigma, no ageism, and no bias. Those are ideals we seek to provide. And the consultation service, different consultants have slightly different views on the standard of care, which is somewhat broad, to help anyone calling understand the breadth of what you can choose from and trying to help your patient's needs. Next. Okay. Please understand this is a well-recognized problem in government, in public health, and I believe in our training programs as well. The population is aging. Okay, the baby boom generation is getting old. People that are now using opioids properly and improperly will be getting older, more frail, more vulnerable to opioid side effects and complications, and there will be more of them. It's been talked about in committees. Next slide. Okay. Remember, in general, we want to go low and go slow for opioid prescribing for anyone. And that in the elderly, as we remember from geriatrics and internal medicine, we have reduced metabolism, reduced clearance, increased body fat volume in stores with decreased total body water, right? There is metabolic accumulation with some changes and even slowing of metabolism. There can be increased cardiac conduction disorders because the cardiac conduction fibers are atrophying, aging, and developing entropy as we age. And there are neurotransmitter changes as well in the brain volume, brain function, all of which adds up to a smaller therapeutic window. Okay. You'll have all the usual side effects of a medication and polypharmacy in the elderly and more of sedation, confusion, memory loss, falls. Constipation is the least of our worries in some ways. And also when you're older and elderly, your rate of dying from an overdose is significantly higher than when you're younger. Again, a decreased therapeutic window all around. Okay. As well as we age, we have social, cultural, emotional entropies, baggage, scars, and weights to carry, which include more pain, more alcohol use disorder, more isolation, grieving, depression, and the overall illness burden of aging. In general, buprenorphine is considered to be significantly safer than methadone. If you are considering methadone, we encourage you to call us first because of its complicated pharmacokinetics, and it is an unusual medicine to use and requires a lot of expertise to do it comfortably with the most safety. Next slide. Okay. You can ask different researchers. They can say being elderly starts at age 37. It can start at age 87. Honestly, studies start between those ages, 37 and 65, and in between. We're not going to dwell on the definition here. So, okay. It's difficult to recognize in older people because of their other illnesses, and not many of our treatment programs are addressing the elderly, and we'll talk about that on our fourth case. Next slide. Again, we'll have the slides available for afterwards. Important thing to note is that suicidal intent among older individuals is significant. It is rising. Opioids are an accessible way to risk one's health or even lose one's life. Okay. While the rates of abuse and misuse are lower in the elderly, the rates of complications and dying are higher. Thank you. Next slide. An example just to remind us that there are dependence questionnaires we can use to try and gauge risks of dependence, which will happen in any individual, any normal human being. Our concerns are more when it becomes an addiction, which is a different and much more severe condition than normal tolerance. Next slide. There are some guidelines, US and Canadian. We took some excerpts here. Some of the main questions and main approaches that may be the same and different in older individuals include how do we reduce the risk of an opioid use disorder when prescribing for the elderly? Okay. Going low, going slow, and increasing slowly. We want to use the lowest effective dose, the weakest formulation, and never change it in less than 3 days or 7 days even. Try to keep it to less than 3 to 7 days if for an acute illness. And always advise elders, especially who are at risk of abuse from others, of storing them safely, preferably under a lock. The rules are to never share them, and please return any unused medicine. This applies as well for hospice and palliative care, but they have their own procedures to do the same. If an older person is at risk, how do you reduce the risk of overdose? Okay. Be aware of the polypharmacies and the comorbidities. Remember our geriatrics. Okay. You want to keep attempting to taper slowly, and you keep attempting to taper often. We recommend, or can recommend, as little as a 5% drop every half month to 2 months, with pauses in between where the dose remains the same in a very stepwise, careful manner. Remember, even the same dose, there's tolerance with age, but there's also increasing vulnerability to the effects of medicine with age. So you may find that even with tolerance, their overall ability to compensate for the dose, tolerated dose, and receive benefit from it can go down, and a lower dose may be equally effective and safer as they age. Always make sure people have naloxone at home. Okay. Next slide. Okay. Here we are. How do we screen? Same way we screen for everybody. There are several of these tools listed here. Okay, review the medication list regularly and often. We do recommend the urine screens be random when you can. Some practices are better set up for that than others. The frequency can vary from every week or two to maybe once or twice a year, and we've discussed that at previous seminars. Okay. Also, when you're assessing an individual, an older individual, okay, explain to them optimistically, because there's extra stigma in our older generations, okay, with optimism and hope that dependence is normal, addiction is treatable, okay, and especially older women, as well as older adults in general, can do better with treating addiction than a younger population. Next. Okay. Again, buprenorphine naloxone is considered to be first line. in managing opioid withdrawal. Methadone is the alternative, not the first agent. Remember adjuvant medications to deal with constipation, Jason, other ideas for other comorbidities that you would approach and prepare for in the elders when withdrawing?
Yeah, I mean, I think, what comes to mind is just behavioral health conditions, obviously how people react to stressful situations. So I think that means something to we think about chronic pain and use of opioids. I think behavioral health is clearly not a medical, but clearly is ways that I think patients may have difficulty coping with it, especially if they've been on medications for a while, or just the uncertainty of a new diagnosis or all the stressors that come with misuse and addiction to opioids.
Yeah, and while some of our younger patients may be cautioned about co-sedatives, alcohol, and others, it's even more imperative to always caution our older citizens. Next slide. Okay. All right. Watch especially when you are starting or changing an opioid program for an older individual. The sleep apnea risks, reduced breathing, absent breathing, cognitive impairment, which you have to differentiate from their baseline, and other normal changes of aging, normal for the pathology they have. And also the risk of falls is very high. If you're concerned, whether it's physical, social, psychological, or other comorbidities, they will more often need inpatient management than a younger person. Next. These are some resources which we'll have on the slide set and we have on our website as well. Just to let you know that you are not alone, that you can call us and our resources for you. This can be done. It can be done easily with practice, and it can be enjoyable as well. Next slide. Okay, do we have any initial questions before we go to the cases? I did want to make a pause here and see if any hands go up. Okay. Emily has a look there. Can we go to the next slide? Sarah has a question. Yes.
Yes, Sarah. Ask it. Oh, thank you. Many older people are on long-term opiates for pain management. And of course, they may start those medications at a younger age and then gradually become older. Do you have any specific guidelines for looking at the issues of distinguishing that from distinguishing the pain management that's an ongoing need from the dependence which comes along with it, and when to begin to look for the need for tapering?
Well, I'll let Jason pitch into in a minute. I would say that dependence, from my perspective, is not the primary concern. We're not necessarily looking for dependence. We're aware of it because it may require dose adjustments. The issue gets down to signs of use disorder, which is one of our last slides. And that's really the indication. For instance, just briefly, are they asking for higher doses every time, specific medicines by name? Are they getting prescriptions lost or stolen often? Are the pill counts off? Are the screens of the urine inaccurate, or at least by the chart record, they're inaccurate? And Jason, do you think of other things you would look for?
I would agree. Yeah, I mean, the concept of, if people who are on opioids for years, they're going to be dependent, and dependent isn't always a negative thing, right? It may just be a physiologic dependence. But I think that just the whole category of just loss of control, I think, is something that typically we see first, which Stefan was just alluding to, all those kind of behaviors when patients do lose control over their prescriptions. So, of course, elderly are confounded by, new things pop up, right? Where new osteoarthritic conditions, new pain syndromes, new cancers that cause pain. So, the trick or the challenge is when, an elderly person who's presenting with all of these kind of behaviors, that their pain isn't controlled. Is that addiction, worsening addiction, or is there something new? So it's almost like you need to reset and do a differential and determine if they're like why your patient is asking, for more medications or early refills, or what's happening here, like pseudo addiction versus something else. So.
Yeah, thank you. Very good. I'd like to take one more question before we go on because we're trying to manage the time, and I think Peter McConnery has his hand up too, if that's all right. Peter, if you can unmute. Okay. If I can't hear Peter, I'm going to go on to the next slides, and then we can try and catch up at the end with questions too and comments. Can we go to the next slide then, Emily? Okay. We have one of 4 cases, and I appreciate Jason chiming in whenever you'd like to here. Our first case is a moderately younger elder, 62 years old, who's coming to you new. And the key thing here is they have chronic pain. You're not sure where from. They're not really sure either. It's from all over. The urine test shows methadone is not there, even though they prescribed it. Oxycodone is not there, even though they prescribed it. And fentanyl is. Questions that will come to mind initially would be, is it opioid use disorder? Is there cross-contamination? Is the patient engaging in other activities of hazard? Are they at parties? Are they smoking marijuana from an unsourced location or person? Are pills being touched that are cross-contaminating? And you can do more screening. You may reconsider methadone at all based on their age as well as the lack of it in their urine. And do they have an old use disorder that wasn't in the record as well? Jason, if someone's older, what do you think? Is there anything else you would do different because they're older?
Well, yeah, I think you'd just be more concerned about resuming medications in this situation. There's a lot of reasons not to, because of the concern that they're not in the urine drug stream, but just, in terms of the dosing, giving, you're not quite sure exactly what's going on here. So maybe there is very good reason for why there is no methadone or oxycodone in the urine, and then just restarting them up, the patient may just not be able to kind of, tolerate that dose. We always worry about elder abuse. Like, is there something going? Is someone taking this woman's medicines or something, or what's going on there? We worry about that with any patient. Obviously, the elderly are more vulnerable. So, is there, someone taking her meds? So those would be kind of some things I would, new patient. There's a lot of things. The heat differential here is pretty big. Obviously the fentanyl is concerning with just the safety issues and the high likelihood of an OUD, but there could be many things going on here.
And my first stop would be, no, I'm not prescribing at this time. I'm going to interview, talk, negotiate, and explore. But my starting point is show me why I need to prescribe a controlled substance at this point. So, Chris, did you want to say something too? Chris Shanahan's joined us. You're on mute still. We all do that. You could unmute.
Mute. I see somebody else has their hand raised before me though.
Well, no, we were talking earlier. We're trying to manage the time. If you'd like, we can have everybody's questions answered now.
Oh, okay. Well, all right. So I guess the one thing I wanted to mention on this was that it makes it different because it's really important. I think the point here is it's so easy when you see fentanyl in urine to just jump and say, boom, there's something bad going on, time to run. And I think what this story tells us is you have to figure out the story. It's real. There's a wide range of possibilities that can explain why fentanyl's in the urine. And it's so easy for us as physicians and as clinicians to just jump and say fentanyl should not be there and make an assumption when it could be explained away or at least clarified and ultimately keep the patient safer. Because you might say, oh, there's fentanyl in there and we need to stop this right now. Otherwise, but what if this person, ends up going and seeking alternative sources to manage their pain above and beyond or in addition to their substance use disorder, and they get a hold of something that's actually more dangerous? They could die from it. So the point is that a fentanyl positive the only thing it'll ever do is cause you to ask more questions. It is not an answer in and of itself.
Next slide. Let's see if we can follow up with that. Okay. Frankly, I'll be perfectly honest, I'm not blowing any smoke here. I find these some of the most enjoyable and challenging and productive visits for new patients or even old patients that are in my practice. Um, and if you don't know a patient and you're not sure how to start with a new patient, new history, as Chris has said it earlier, it can blow up. It can just turn into a complete nightmare visit. Um, so approaching it for the very motivational, open, non-judgmental point of view of tell me more about how you're doing, how your pain is, where is it, and try to with open-ended right questions and normalize the negative. So not are you smoking, but how much are you smoking, right? Typical tobacco use disorder counseling. In this case, it may be hard to take your medicine. What makes it hard? How often do you miss doses? How often do you have to use something stronger? Lead with the stigmatizing pejorative so that the patient feels comfortable telling you more.
I mean, you could ask the person, why is there fentanyl in your urine? Or you could say, tell me how you're managing your pain.
Mm-hmm.
It's the same question.
Yeah, exactly. But it's said in a way that the patient will give you the information you need to make this
Right.
visit productive.
And it's non-judgmental.
Very much. Yeah, that's right. And in older folks as well, again, different culture, older, not to box people in. It's even more stigmatizing to talk about. So you'd be even more of this approach than you would with a younger person, perhaps.
So, and in this specific example, after you say to the patient, so tell me how you're managing your pain, and they go on for 2 or 3 minutes, and the word fentanyl does not end up, then you say, well, listen, thanks for explaining that to me. I'm a little confused about this because we found your fentanyl in your urine. Is it possible? Do you have any ideas about how that could be in there and how that could be helping you with your pain? Why is that in there? Find a way to make it non-pejorative. Just talk about it as a fact without any judgment, and you're in a better position to kind of sort out what's the next thing to do.
Yeah, it's much more effective. Next slide, please. Okay, so it is too early for a plan. That's the message of the first case. So we are emphasizing and re-emphasizing what we've talked about here. The opioid use disorder, prior or undiagnosed, is only one of many huge range of possibilities. We're aiming to be safe. You may want to consider buprenorphine, which again can be used for mild to moderate pain in a patient that's willing to trial it, or even a methadone clinic. Although if they're not taking methadone, it's not in their urine, there may not be, unless they're in withdrawal in front of you, there may not be much reason to rush to treat.
Right.
And then as far as inpatient treatment programs, we'll repeat this a few times, not necessarily the best option for an older person, not necessarily the safest, most comfortable, most accessible. Would you want to put your grandmother, as Chris has said, into an open access detox where people walk in and out all day? Think about what else goes on in a shelter or a detox of that sort, no matter what the people do to make it safer.
I mean, outpatient detox is it's an important option that we should consider if it's safe, and it can be done. Certainly with opiates, especially if you're controlling the opiate that they're having problems with, and you can get them so that they don't purchase or have access to additional stuff. You can do it if they're on board. Was this patient on board?
Yes, they were. So we'll go to the next case, I think, as well, and we'll come back to these at the end for questions too. So please take any notes. Next slide. Here we have a mildly elderly gentleman, okay, alcohol use disorder, opioid difficulties in the past, with some severe liver disease. They are not in liver failure. PAUSE apparently is an acronym for many things, so it's a little bit of a challenge to give the resources for this slide. In this situation, this is not a pediatric issue. This is alcohol withdrawal prediction index, and they will most likely, with careful management and careful observation, do fine inpatient, be managed when they become difficult inpatient. What if they don't want to be inpatient? Okay, they want home detox using benzodiazepines, which inpatient is reasonable, and outpatient has been done. There's no reason to prevent them from having naltrexone. Naltrexone can be given to even a healthy person, and we want more access to it. And they also want gabapentin with the benzodiazepine, both sedating medications. One of the issues in this slide in this case is to remember that as we get older and more frail, and there are models of health and illness related to frailty over the life trajectory, that a PAWS scale is not elder dependent or age dependent, but as you age, your PAWS scale will increase because you inherently have more risk of disease and more risk of complications from now not just 1, 2, but perhaps 5 or 8 or 10 attempts at alcohol withdrawal in your life because you're older. Ready for the next slide? What would we do? Okay. All right. They're in pain. They need detox. Detox first. Okay. Safety first, comfort second. Unfortunately, that is a very good guideline. The outpatient ETOH detox would need to have a lot of support, family, community, friends, someone there 24/7. This is fairly standard, but even more so in the elderly. Okay. Think about lorazepam. It's not the longest acting. It's not necessarily a best choice outpatient, but it's less metabolized through the liver than Librium or Valium, which are more common, longer acting choices that don't have quite the up and down seesaw serum level that a shorter acting lorazepam can have. And have a very, unlike a younger person, you're going to have a very small tolerance for side effect and complications. So an elderly person has a very small tolerant therapeutic window. They also have a very small tolerance window. The risk of complications proceeding rapidly is much higher. So referral to inpatient, transport to inpatient services can happen much sooner. Naltrexone in this case, with their cirrhosis, becomes a relative contraindication. I don't know that it's absolute though, Chris or Jason. How do you feel?
Well, the flip side of that is we do have this person would be qualified for a camprosate, so they don't have brain failure.
That's fair, because we're looking at primarily alcohol use disorder where both can be indicated.
Right.
One of the reasons for pain management is to also avoid alcohol relapse, and as we know, one is too many, 100 is not enough for any addiction. It is very hard to maintain sobriety without that substance or behavior longer term, and anything can trigger you or be an excuse to be called a trigger into a desired behavior that's damaging to self. And in this case, alcohol, liver disease, opioids together is difficult. And so buprenorphine is often, I find it a first choice, again, for mild to moderate pain in a patient that's willing to give it a fair shake and can be very effective. It's not for significant severe pain issues with very high doses of opioids where the patient doesn't want to make the change. It's not going to work then. Any other thoughts before I go to the next slide, which would be our third case? We have plenty of time right now to point out what's different in the elderly here or take more questions.
I know you mentioned it probably appropriately, Stefan, like 3 or 4 times, but starting buprenorphine in this patient, it's an opioid. They have liver disease. There's metabolism issues. So I saw a case of a elderly patient who was started on buprenorphine. Probably some stigma attached to the case in which they just kind of assumed, oh, she's homeless and we just will start buprenorphine, but she was actually opioid naive, and became delirious and they couldn't figure it out. And she was on it for pain and ended up in the ICU and looked at the dose escalation. And it was, giving an elderly patient with liver disease, low to even moderate, even high doses opioids can cause trouble. So she does have that history of OUD here, or he does in this case, but I would probably presume that he is kind of opioid naive at this point and be very, very judicious in starting buprenorphine, even with that history of OUD. So I think we're very aggressive with giving buprenorphine for people with OUD and getting doses up very aggressively, but taking a step back, liver disease, elderly, relatively opioid naive, just being careful with using any opioid, whether it's oxycodone, Dilaudid, or buprenorphine.
And if anyone's asking what is the dose, tell me. 2 or 1 milligram of buprenorphine to start with, several hours assessment in between that second dose. Oxycodone 2.5 perhaps, no more than once or twice with monitoring. And again, there's a range, but this is within the reasonable range of low dose going slow for an elderly patient. Next slide, please.
Baby doses.
Babies doses. Okay. So we have here a 61-year-old woman, okay, complicated more than the usual complication because all of us arguably have some bit of behavioral issue or challenge from our lifetimes now. In her case, it's very unstable, very poor social structure and supports, significant non-adherence, delusional at times, paranoid at times, intermittently street and homeless, who has chronic pains, including migraines. It's I can say toxic mix of agents in the past and present. And we're looking at those right there: gabapentins, the somas, furosets. Duloxetine, again, not toxic. It's a very good combined antidepressant with a pain indication. But now we're into polypharmacy. It's being mixed with everything else. It's the everything else that we would worry about, really. And then borrowing medicines from a friend. Okay. Now she's on Suboxone, essentially, and duloxetine at even a higher dose. And then normally it goes 30, 60, or 20, 40, 60. 90 milligrams would certainly be considered a highest dose and possibly off-label there. The gabapentin is at a substantial dose. Again, you can go to 900. The Nurtec is accepted for migraines, and Furoset, which was, she got an additional 20 tablets of Furoset just one time from her neurologist. She's done in a week. So she is begging for Soma, adding Soma in. She's declining other agents that you would consider to be in the sort of, not junk category, but the group box of muscle relaxant, because they're all very different classes of agents and mechanisms. Basically sedatives, not called sedatives. And she will only take the one by name agent of Soma. Okay. She did not make her appointment to interventional pain management, even if most are basically surgical interventions. And we really want people to help manage the outpatient pain, and that's hard to find. She did not make that appointment either. Can we give Soma? Would you give Soma? When would you give Soma? Anybody have any ideas? I'm curious to see what people are thinking right now. A bit of the history while you're thinking there. Yes, Soma is the prodrug for meprobamate, which was pejoratized, if not off the market, after many little old ladies were looking for that blue pill in the 50s and 60s from their kindly primary care doctor, who kept them very happy every month. It's not considered safe to use, but being a prodrug with a slower onset metabolism to the active agent, they consider Soma less addictive than its predecessor. Okay. Maybe we'll go to the next slide then. What do we think? Okay. Chris, do you want to do your pleasant diatribe on Furoset and Soma at all, or?
Well, Furoset is it's a combination drug. If you're not familiar with it, it's butalbital, caffeine, and phenobarb. And no, excuse me, aspirin.
Sorry.
So it's butalbital, aspirin, and caffeine.
It's interesting. I checked the slide, and there are forms that have Tylenol instead of aspirin presently, and
Interesting.
pain.
Well,
and go ahead.
The deal with it is that 2 or 3 of the ingredients cause a withdrawal syndrome. So if you take this thing chronically, and a lot of these patients do take it chronically, you can get a withdrawal syndrome from this medication that feels exactly like the disease you're trying to treat, which is the migraine headache. So I highly advise trying to avoid this medication if you can, because it doesn't solve anything, and it just becomes a You just have to refill it over and over and over again. And the patients won't come off of it because they get sick when they come off of it. And no amount of convincing them that this will go away works. So if you can avoid and stay away from this stuff, I would.
Yes, Elizabeth.
It's particularly
The-
galling because it was designed at Montefiore, which was where I trained, and that's why it's called Fioricet. It was at Montefiore in the Bronx, which is considered bothersome to me. Anyway.
We had a clarification. Fioricet does have the Tylenol. There's a, I'm guessing Fiorinol or something.
There's Fiorinol and Fioricet. Yeah.
Yes. And it is butalbital, correct? Yes. I mean, I find Soma, Fioricet, and benzodiazepines chronically in general to be on my list of medicines I really want to taper people off as quickly as I can. And it's the same challenge. It's worse because of the withdrawal effects here. But as we know, there are prolonged withdrawal effects for many agents, including benzodiazepines, that can last months to a year and more after you're off of them.
And it's really hard to get these people off. I mean, I have an elderly lady. She's got chronic pain. She's got migraine headaches. And she absolutely begs me, you can't stop this medicine. You can't stop this medicine. And, because the risk is on the lower side, even though I don't like it, I continue it. But, that's the challenge of this kind of care.
So because this person is older, we're talking about elder care of opioid use disorder and similar issues, we are more likely to almost set this is what we're going to do than a younger person, because the cumulative risks with age are significantly higher than they are with the younger population. You can say that it's my license on the line that I need to be here to prescribe for you safely for years to come, and this is what's medically indicated. This is what's medically necessary.
But I would argue that you don't really need to get in. I mean, I do it sometimes myself and say, look, this puts me at risk.
My last card, it's like my last card I play. I want to be here for you, and I, but yeah, you want to be more firm about and more follow up carefully to taper these doses in the elders. You want to, because they're elderly, you want to make sure they have more frequent lab monitoring of liver function, renal panel, and also mental status assessments at visits, which you would not really consider so much in a younger person. And it's especially with the Fiorinol Fioricet, remember that many of the side effects, the withdrawal side effects, imitate the pathological parts of the aging process. The weakness, the dizziness, the disturbed sleep patterns, restlessness, tremors.
There's just no wiggle room with these older patients.
Everything's narrower. Therapeutic window, tolerance for complication and adverse outcome. You're aiming, if you didn't start by going low and going slow, you're aiming to get back to, as they're on the downhill slide, and aging is a downhill slide, unfortunately, truthfully. The doses have to go down to slower, lower doses before you're forced to by an adverse outcome, hip fracture, sudden fall, intracranial bleed. So.
I think it's very easy to remember to go low and go slow with these patients. What's harder to remember is that these patients can get into they can have just as much crazy behaviors and do as crazy things as younger patients. Like, we might not think that the lady is snorting cocaine with her grandson, but these things happen. And we can't allow our own prejudices to not screen for this stuff.
And there's an example of a negative stigma. You don't want to cut extra slack to an older person because they're not the same older people we knew 40 years ago when we were young. These are the new generation. Also, even then, it was have a stigma. That
all these 70-year-olds grew up in the 60s. They were all dropping acid.
Remember, cannabis, yes. So let's remove the stigma, even the positive stigma that somehow they don't have to be causing, the same troublesome issues. Peter, did you want to ask a question or make a comment? If you unmute.
Yes. This patient is on buprenorphine. Does she agree that she has an opiate use disorder?
I sometimes will approach it that it's for pain and then get to the rest later. I like to talk about dependence rather than a use disorder first. Um, Jason or Chris, what's your approach to that question?
This lady doesn't have a history of OUD, right?
No, it's mental illness, and it's more a matter of
Right.
she's more unsafe to prescribe for her in general because of her disordered
Right. So
homework.
she makes poor decisions, and her judgment's not that great.
Use
So
of overdose, I would say, really.
yeah. Yeah. I mean, I think the problem with buprenorphine is that it's used for two different types of conditions, and we often don't specify as clearly as we should what we're doing. Sometimes we're not even sure what we're doing. We think we're treating pain with the buprenorphine, but maybe we're treating a little OUD.
I mean, one of the beauties of primary care done well is that we are trained to deal with uncertainty. I don't necessarily need to know, nor do I need
Right.
to necessarily prepare the patient by telling them more than they're willing or ready to hear, because it's about the relationship, the trust, and working through towards that discussion, which may not happen right away.
Right. So one way to approach this would be, I'm worried about your safety.
Mm-hmm.
These medications can be dangerous. I want to make sure that everything we do is safe. And so this is how we're going to approach it. This is how I'd like to approach it. So you're coming at it from a safety perspective as opposed to, this is scary. I don't like doing this. I could lose my license. It's a very different thing. It's all about the doctor or the clinician as opposed to it should be about the patient.
All right. Next slide. We'll come back to these after we're done here. So this is our last case, and this is a much older woman whose behavior is a bit odd. She does have opioids for a pain condition. She states she firmly has never used, does not use cocaine. She has progressive Parkinson's. The gait is more shuffling. The affect is flatter. She has a bit of kyphosis in her upper spine, age-related posture changes. Not a very athletic person, and she's had some past falls already with injuries. She's a fentanyl patch of 75 micrograms transdermally, and gabapentin for pain. Now, there is cocaine in her urine. There is a chart record at some point in the past of opioid use disorder. Patient's daughter is there to help. She's there to translate. The person speaks English, but she's there to translate the mother's needs when the mother sits there quietly and doesn't say anything. But you are uncomfortable with the cocaine and fentanyl in the toxicology because what kind of fentanyl is it? Who distributed it, manufactured it? Is it the prescription you gave or something else? And then there's a stigma around cocaine, and we've touched on this before. I have in previous talks. If you look at the chemistry, and we're all trained as chemists to get to med school and through it, cocaine and Ritalin, meth are not that different. They're very similar chemical moieties, and other stimulants such as cat, chewed as a leaf in the Middle East and elsewhere at parties with alcohol and tobacco, is very closely related to Wellbutrin, bupropion, from the same cathinone derivative. So is that a stimulant? Is it an antidepressant? It's marketed as an antidepressant. It certainly is a stimulant. So one of the main side effects is to up-regulate someone who's feeling still down and unmotivated when their depression is being treated by something else, as SSRI. So what is really so wrong about cocaine? At some point, is it a reason to stop other treatment that's medically necessary or indicated? Chris, you and I talked about that a bit just earlier this week.
Yeah, I mean, I think it all comes down to the story. I mean, how is that where is that cocaine coming from and under what circumstances? And does it represent a real risk, or is it just contamination because of other behaviors? And this is where having a relationship with the patient is really important, because they got to trust that you're not going to jettison them when they tell you what's really going on. And so, as you've heard over and over again, the angle here is always to kind of focus on safety and concerned about their well-being, so that it doesn't look like you're trying to catch them. It looks like you're trying to keep them safe.
It's not always true in practice. I mean, as primary care clinicians and others on this line, um, theoretically, the relationship and the trust allows us to really get a lot further in this discussion and managing the pain and other issues more safely. Practically speaking, there are some patients who will refuse to see me because they know that Dr. Topolski tends to always want to, go down on the medication, no matter how old the person is getting. So, and you can't really argue with word of mouth in the community or on the street. So in this case, we have her daughter stepping out of the room at one point, or was late to the appointment, and her mother brought herself in. What's Elizabeth's question here or comment? What did Elizabeth just write? I wanted to read that chat.
It's saying it sounds from the case as if there may be some issue with the daughter, but chances are the patient is dependent on that daughter as well. So just the concept of, how the daughter fits in and who's dependent on who. We have dependence on substances, we have dependence on family members here.
Yeah, I think you've got a bunch of one-legged people that make up one person together.
But again, it's more common in the elderly, so we can approach from different angles. Is this a behavioral dysfunctional codependence? Is the mother at risk of both abuse, neglect by the daughter, but also needs her for her self-care and activities of daily living? So we're not going to go into all those wonderfully, colorful options that we get in primary care, where every visit can be different. It's highly complex. But in this situation, as an elder, we're challenged with how much we can intervene without alienating the daughter, which could then harm the mother in other ways, even while we're trying to answer the mother's request to reduce her opioid exposure. And the daughter may simply be very concerned that she feels her mother really needs it. She doesn't want to see her in pain. That's not the point of the case, because the case is just a short presentation on these are issues you see in the elders. This is what makes elder care with opioid use disorder, past or potentially present, different, more challenging. Peter, you raised your hand.
Is it ethical at this point to get a tox screen on the daughter?
Oh, my 2 cents is that you can always ask for it. I mean, the question is, are you going to secretly get a urine sample from her somehow and test it, or are you going to test it without her permission? No, you can't do that. And it would be nice to be able to.
No,
not
secretively. When the daughter walks in, say, your mother's got something very complicated going on here, and I don't really understand it. Would you give me a urine sample? I want to check your urine tox. And if she says, no way in hell, I think I've got a lot of information. If she says yes, you've got a lot of information.
Yeah,
I would.
No, I wouldn't. I wouldn't do it I wouldn't do it secretively. I'd do it right up front.
Even if she refuses, you can't say that definitively tells you what's going on. I wouldn't want to be urine drug tested, and I would say no, just on principle.
If I like and trust my mother's doctor and they're smiling at me and I have nothing to hide. But again, everybody's so different psychologically that we're going to go to the next slide, see what Sarah has to say, and try and bring in some points in this case. Yes, Sarah?
Well, you really don't have any idea what the actual relationship is between this woman and her daughter. You have possibly a woman who actually doesn't want to be on these medications because perhaps they are affecting her in a way that is negative or experienced as negative for her, and the daughter has some other agenda. On the other hand, maybe the daughter is right and the woman is trying to do something which is detrimental to herself, and has been on a stable regimen, and the daughter is simply trying to protect her. And there's a huge range of possibilities in between those two things, which
that's why we say
more info.
This is our last case because we're serving up this platter of delicious, qualitatively complex possibility. And as a short case, our points here would be that there are many red flags, and we don't know. It's very hard. First line, it's very hard to know what is happening. Because of her age and falls, high dose fentanyl would generally be contraindicated. unless you're absolutely certain about the pain diagnosis etiology that this is the only or best option for her. The cocaine at this point doesn't concern me so much, at least. The daughter's presence is very concerning because I don't know the background. I need to know that. And passive diversion is very common in folks that are ill or elderly. Another reason to be even more, it's different from younger people where it happens, but the person is usually going to be aware of it. This older person may never be aware of it. And certainly the daughter could be using some or selling some. I guess here, to respect the mother's wishes as a patient-centered care, I would absolutely be tapering her slowly. That's her wish, no matter the risk, because this is about the dignity of risk at some point. And an elderly mother has the right to lower medicine, even if it's not in her benefit from our point of view or her daughter's point of view. A slow taper is absolutely indicated since that's the patient's desire, with no short-acting agents to complicate or endanger our patient at the same time. And if we do find that we can get off medicine, reassess her pain, reassess her function, get a real baseline for where she is. Again, elderly care involves more baseline assessment than it does in somebody younger. Younger, it's about functional goals. And the older, it's about, well, what's our functional baseline, first of all? And are we maintaining that or losing that through our medication? And then the referrals can be to outpatient or inpatient, preferably outpatient methadone or buprenorphine care. Buprenorphine would be a first choice unless there's significant liver disease.
Stefan, can I offer some suggestion?
Sure.
When I have patients like this where it's pretty clear they're stuck and I'm stuck because I don't know what's going on and I don't know how much they're going to cooperate and I just don't know what's going on yet. Sometimes, and I want to do something, I want to feel like I've got a plan. Sometimes my plan is get this person back here quickly. In other words, lots and lots of follow-up. In other words, instead of saying, I don't want to see you, come back in 6 months, come back in a week, come back in 2 weeks, come back in 3 weeks. I want to see you more frequently. And I do that because I want to observe the mother and the daughter together. I want to see how their relationship, I want to see how they are interacting and whether things are getting better or worse and whether I can work with them or not. So
I need to set in there. Oh, give me a second. Please give me a second. In primary care, in my small community, I can sit in my office, look out the window and see people with their family or others walking in and walking out. And that's when I really get to see how they behave and how they feel, not when they're in the office, limping in the door and falling into a chair. It's very different day and night. Just saying it's an advantage I have.
That's really critical. And so I guess my point is it's okay to do nothing and just say, I'm really concerned about this. I'm not sure what we're doing. I want you back next week. And we're going to continue this conversation. That's simple. And, so anyway, that's what I wanted to offer.
Very valid. Very, very true. I'm happy to stay on as long as anyone wants to. We have 1 or 2 more slides to round out the hour. If we could jump to the next slide. In conclusion, next slide. Aberrant behaviors, opioid use disorder at any age, from the least to perhaps the most concerning. And thank you, Chris. I did get that put back in here for you, although it lined up differently on the.
Oh, that's all right. I mean, red is bad.
Red is bad. And the illegal one at the bottom is supposed to be the reddest of the red. Because that's really hard to make sense of any other way, but no. And then we'll go to the next slide. And this is, again, the DSM, unless it's been changed. I should check again and see. Guidelines for the same diagnosis. Okay.
And again, I would just emphasize, pull this list out all the time. Don't assume the person has the diagnosis. You want to give them the diagnosis and you want to stage it. You want to tell them that they have mild, moderate, or severe. And I find that when I read those questions to them, and I do it myself, and there's just this kind of level of like, yeah, I did that. Yep, I did that. And it's kind of like at the end of the diagnostic process, after 3 or 4 minutes, you're on the same page with the patient. And because the questions are scripted, there's no opportunity for you. If you just read the question, there's no opportunity for you to even put any stigma or any kind of, affect on it. So you can't even screw it up if you just read it. So anyway.
I'm going to print this and put in each one of our rooms for our team just now today, because I'm just realizing.
I basically have as a quick text on my OUD patients or my substance use patients. I just pull that up in and I just slap it in and I go down and say yes, no, and in 5 minutes I've got it done. And it's certain. You might say, oh, it's another screening test, but in some respects, it actually serves as a history too, because what will pop out are stories as you ask it. So it's
an eye-opening and empowering for the patient as well.
Yeah, it is. It is. And again, it's like they're stating it out loud. It's almost, I don't want to say it because it sounds weird, but it's almost like confession. It's kind of like you're getting real with the patient. They know what you got, you know what they got, and you know that they know what they got. Anyway, I'll stop there.
We have a question from Elizabeth about advice on, can you read that? Let's see.
Can't see it.
Advice working on issues of very homebound patients where it's extremely difficult to get into the office and cannot manage televisits. I can't answer this because I see the house calls, so that doesn't apply to me. Okay.
Well, the answer is get transfer to PCP Stefan Topolski. That's the answer.
Well, that's just no, it's fine. It's a serious question. If I could not see a patient at home, and it does happen sometimes, it's like working in the dark, and having someone controlling the medications, family otherwise, is almost essential, or I can't do it.
Yeah, you might be able to pull it off if you have a really engaged family member that's got a clue and has got good communication skills, but nothing substitutes to talking with the patient, seeing them.
Sure. For those that are staying on the line, we're happy to stay as long as you like. Any other questions, comments, advice for us too? I'm looking to see if anything else.
Feedback.
Mm-hmm.
Well, I don't see any faces on any of these people, so these are people might have been people that have stepped away. So,
very good. Well, I want to thank everybody for coming. This took a lot of preparation. It's been wonderful, huge fun to prepare for you, and we're available for any questions and comments. Yes, Sarah.
I was just going to say thank you. It's a series of very challenging problems, especially with the elderly homebound person. Much food for thought. Thank you.
they're tough.
Glad
They're
to
tough
help.
patients.
Thank you.
You know,